Hello everyone, and thanks so much for joining this meeting today. The topic of our conversation is the unmet need in rheumatoid arthritis in the context of pain, and I'm delighted to be joined today by two fellow rheumatologists here in the UK. First of all, my colleague from Cambridge, Dr. Nick Schenker, is going to be talking to us about the burden of pain in rheumatoid arthritis. I'm then going to move on after that and talk a bit about mechanism of pain in the context of rheumatoid before having our colleague in Oxford, Professor Peter Taylor, talk to us about the management of pain in rheumatoid arthritis, particularly in the context of JAK inhibitors. These are our disclosures. And a few housekeeping pointers. You listening in are all on mute for the duration of the meeting, but we really want to hear from you. So could you use the Q&A function for any questions that you have? We'll have opportunity after each speaker and then at the end to address as many of the questions that come through this particular function. We also appreciate that technology can be challenging at times, and if you're having any technical difficulties, we've got a great team working hard in the background, and if you could use the chat box to communicate with them, should you be having whatever problems listening or seeing us. So this is our agenda for the next hour. As mentioned, Nick's going to kick off, followed by myself and then Peter. And then hopefully we'll have time at the end to pull things together. So it's a great pleasure to first of all introduce Dr. Nick Schenker. Nick's a lead clinician and full-time NHS consultant at Addenbrooke's Cambridge Hospital, and it has been since 2007. He has particular interest in managing patients with complex regional pain syndromes and is actually a founding member of the CRPS UK Society. It's a national cross-speciality network of clinicians and researchers. He got his first degree at Cambridge University before completing his medical studies at Oxford University. He trained in rheumatology in London and completed his PhD at the National Hospital for Rheumatic Diseases in Bath. He has a strong interest in pain and has done for many years. I'm really looking forward to hearing his presentation. Over to you, Nick.
Thanks very much, Neil. And thank you very much, everybody, for logging on. I know how busy life is at the moment. I've got a remit here to look over the prevalence and the impact of pain in patients with rheumatoid arthritis. So I'm just going to pull my slide set up. And I'm going to put a few slides together, but as Neil said, it would be nice to have some interaction. These things can be rather dry if we're just talking at you. And please do use the chat box to interact with us. And there will be opportunities for questions at the end of my talk. So we all know that pain has a major impact on the quality of life and is associated with psychological distress. I want to show you a slide just outlining the impact on its physical and social functioning. There are strong links to fatigue and, sadly, with low mood. And I just want to spend a minute thinking about the mood question, because I think it can allow us to think about pain in a slightly different way if we view its relationship to mood as significant. People with rheumatoid arthritis live with depression. About a third of our patients are depressed or anxious on studies when you ask them. And this is important because it allows us an opportunity to impact upon either their pain or depression. We know there's a bidirectional relationship. These are just two studies that demonstrate this quite nicely. And that if you start off feeling depressed, you're more likely to report pain. And if you have more pain, you are more likely to feel depressed. And teasing out the relationship in the clinic can be really quite productive, in my view. And this has a real impact in rheumatoid arthritis. And when you focus on patients with rheumatoid arthritis, as Oyston did in their study, then you can show that relationship comes through. Patients want us to look at their pain management. When people come to us in clinic, they want us to focus on their pain. 70% of RA patients consider pain improvement their first priority compared to all other aspects of their disease. And although this data that my esteemed colleague and panelist, Peter Taylor, put together about 10 years ago, shows that the level of satisfaction with pain management is not very good. I think that possibly has improved recently, and I'll show you a bit more data in some slides. But a large proportion of our patients with rheumatoid arthritis, if you ask, are not very happy about how their pain is being managed. And if you look at this study that looked at nearly 300 patients with rheumatoid arthritis, and you strip out all patients who have fibromyalgia, and you give this group of patients 80% or more biological therapies, and you give most of them analgesics as well as nearly half of them steroids, you can get the majority satisfied with their pain management. But even then, 1 in 4 would have a pain score of more than 70 out of 100. And this sort of chimes with my clinical experience and that of other studies as well. James Galloway led a study looking across patients in many European countries who were defined by remission, and found that nearly more than a fifth had moderate to severe pain that's rated 4 or more out of 10. So pain is still an issue, even in those patients who are very well treated. And in the clinic, we must be aware of that consultation gap when patients who come in expecting pain management may not be expecting their healthcare professional to be focused on inflammation, which is clearly a hugely important aspect of rheumatologists and rheumatology practitioners' strategy. But this study just highlights the impact that might have on a consultation when 70% of all RA patients consider pain improvement their first priority. And this is why I think when you follow the day, you follow where the pain goes. It interrupts sleep. It stops you getting ready for work or getting dressed, and it impacts upon your day. And that comes out in just this metric of watching people just not being able to keep in their jobs, for instance. And those with no pain are much more likely to retain their work compared to those who have severe pain. So there's no doubt that pain continues to be a major issue for our patients who have rheumatoid arthritis. And I guess the challenge is how, as we as healthcare professionals, can help with that. And I think the first thing to do is to disentangle someone's pain report by looking at the mechanisms. And I'll segue now into Neil's talk. But I think we do have maybe a minute or two to answer some questions if there are any from the first talk. Thank you.
Thank you, Nick. Very convincing. And a great scene setter for our next couple of talks. But before we go down that track, I was wondering, while we wait for hopefully some questions from our audience, if we could delve a wee bit more into this relationship between depression and pain that you nicely articulated. And I fully agree, such a large proportion of our patients have both, and it's hard to disentangle those two. In your experience, do you find that in some patients treating the depression helps the pain, and vice versa?
Yeah. It's the joy of pain, to my mind, is being able to phenotype or understand an individual so much better in clinic in the brief time that you spend with them. And are you treating somebody who is depressed and in pain, or are you treating someone who is in pain and frustrated? And I do find it quite helpful to try and figure that out. And the GP letters are usually pretty helpful in this regard, because they might well have a long history of previous depression problems. But if the cart of depression came before the horse of pain, or the other way around, that's where to focus the attention. And actually, when you look at nice guidance of how to treat chronic pain, the evidence base points to SSRIs as being the best painkiller. And I suspect they're working through not only the descending pathways that use serotonin, but also the mood alleviating pathways as well.
Thank you, Nick. We have a question coming through. So the question is, are there any data on the impact of antidepressant treatment on disease activity in those people without clinical depression or subclinical depression? And if so, which particular antidepressants? Okay.
I'm not aware of any data that looks at DAS scores as an outcome measure for SSRIs in the population of rheumatoid patients. You might be able to enlighten me if you are. The antidepressants can broadly be divided into those that have SSRI only activity and those that are dual serotonergic and noradrenergic. And the latter include duloxetine, venlafaxine, and sertraline, whereas the former that just focus on SSRIs would be things like fluoxetine and citalopram. You might think that the SNRIs might provide a bit better pain coverage. And certainly when you look at a fibromyalgia patient in a clinical trial, duloxetine has been studied quite carefully. Venlafaxine and sertraline haven't been studied so carefully, but duloxetine is certainly quite effective for the fibromyalgic patient. In my clinical practice, I tend to be following the NHS guidelines on first-line antidepressants, which tend to be much more fluoxetine and citalopram. Sertraline seems to be better tolerated in an elderly population. And duloxetine, I would start low at 20 milligrams, working up. I would start all the antidepressants. Usually, I am comfortable prescribing SSRIs for pain management, but most rheumatologists I know are not. So I would be guided by the general practitioners. Pharmacy. Yeah,
I'm not familiar with any RA-specific studies where the outcome measure was disease activity in the context of an antidepressant intervention. I am aware that there's a theoretical basis for why certain antidepressants may have anti-inflammatory phenomena. But if I was to predict the result of such a trial in rheumatoid, it wouldn't surprise me if disease activity did improve, but not necessarily the inflammatory elements. As we know, and we might touch on through the conversation today, our disease activity measures in rheumatoid arthritis don't just capture classical inflammatory pain, which us rheumatologists are all familiar with. The patient global assessment and the tender joint count may not be the standard measure just of inflammation, and they may improve for the reasons that you've set out, Nick, but not because of alleviation of inflammation, but because of alleviation of the underpinning pain mechanisms, which may be distinct. Peter, do you have an insight into this particular area?
Well, thank you. And thank you to Nick for a very thought-provoking talk, because this is such a difficult area clinically, I think. So I think there are a number of comments that are worth making here. The first is, of course, that there's a triad between depression, inflammation, and pain. And we know that with respect to depression itself, that high IL-6 levels are associated with depression. So there is a systemic inflammatory element to much depression, often at a relatively low level. And it's also the case, of course, that if you experience pain chronically, that it's quite likely to cause a reactive depression. So from my point of view, I would always begin by trying to treat to target and optimally suppress the systemic and local inflammatory response in the individual. But we absolutely have to recognize that some of them, despite that, will still have depression, anxiety, and reported pain. And I think the key thing, and we might hear more about this, Neil, from yourself in the next talk, when we look at the real breakthroughs in contemporary neuroimaging, is the understanding that there are incoming signals through afferents, which are then interpreted not only in the sensory cortex, but also from the point of view of the cognitive aspects of the brain and also the emotional aspects of the brain. So there may be a perceived unpleasantness to an incoming nociceptive signal. And that perceived unpleasantness will certainly be exaggerated in the patient who's depressed. And that opens the doors, that understanding of that triad of sensory, emotional, and cognitive elements opens the doors not only to pharmacological intervention of the sort you've been talking about, Nick, but to non-pharmacological intervention. So in answer to our colleague who asked about the impact of antidepressants in a patient who doesn't appear to have clinical depression. Personally, I wouldn't go down that route, but I would explore mind-based interventions first. And our preference where I work is to look at mindfulness. And we actually find this enormously helpful for some patients, but it has to be said, it's also enormously helpful for many patients who actually have clinically evident depression as well. So I absolutely agree with you, Nick, that it's important to disentangle the different contributory elements as best one can in order to ensure we're treating the right component.
That's great, Peter. And thank you, Nick, for such a clear presentation. I think we'll move on to the next presentation, which I'm going to deliver. So we'll get our slides ready. Great. So, before we get into the weeds around further pain management, I think it is helpful to be able to understand a wee bit about the heterogeneity of pain mechanisms which can be at play in the context of a disease such as rheumatoid arthritis. And by doing so, I expect that will help inform a more intelligent, stratified approach to pain management in patients with rheumatoid. So a good starting point are the IASP mechanistic descriptors of pain. These terms may not be familiar to you all, so I'll walk through these with you. Starting with nociceptive pain. So the definition of this is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors. This is the classical pain in rheumatoid arthritis that we're all familiar with. It's the inflammatory mediators that are causing the activation of the nociceptors, which characterizes this type of pain. Then there's neuropathic pain, and this is pain caused by a lesion or disease of the somatosensory nervous system. Now, in days gone by, our rheumatoid patients on occasion would get a vasculitic neuropathy, leading to neuropathic pain. But with our more aggressive immunosuppressant strategies, thankful to say, and certainly in my own clinical practice, very rarely see such a complication. And so, generally speaking, this form of pain isn't so prevalent amongst our rheumatoid arthritis patients. But nociplastic pain, probably a new term to many, is increasingly being recognized to be important when considering pain in our rheumatoid arthritis patients. And this is defined as pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors, or evidence of disease or lesion of the somatosensory system. And I'll talk a bit more detail about this in subsequent slides. But in essence, it's the balance between nociceptive pain and nociplastic pain that our patients have to endure. And that balance alters according to the point in the journey that the patient has in their disease course. So very early on in their disease, where inflammation is dominant, nociceptive pain is a primary driver and continues to do so as the years go by, particularly around inflammatory flares. Towards more the established end of the rheumatoid arthritis journey, when structural change evolves, here comes another source of a nociceptive pain. But in the background, slowly evolving as the nervous system becomes more sensitized to pain, is this nociplastic pain concept, which incorporates both peripheral and central sensitization. So let's talk in a bit more detail about these different constructs in the context of rheumatoid. So in the context of nociceptive pain, most of you in this audience will be quite familiar with the interplay of various immune cells in the rheumatoid synovium, which goes on to produce in excess numerous mediators, including inflammatory mediators that we're familiar with, such as TNF, and neuropeptides, such as nerve growth factor. And together, these mediators lock onto receptors and nerves, which in consequence leads to upregulation in ion channels and subsequent influx of ions, which go on to depolarize and excite the neurons, leading to the evolution of action potentials, which go down the nerve to the DRG, the dorsal root ganglion, which is really critical in pain processing, onwards to the spinal cord, and then up to the brain. Nociceptive pain, as I mentioned, isn't just around inflammation, though. Of course, a joint like this, if you were to replace this joint, this damaged knee, 80% of patients will experience a transformative change in their pain. And this is a form of nociceptive pain. In rheumatoid, we focus around structural damage characterized by erosions. And common sense would suggest that these erosions are going to be painful and culprits in the nociceptive pain. But actually, there's actually very little data to evidence a strong correlation between small erosions and the pain experienced by patients. I'm sure there is a signal there, but the assumption is that this is a major contributor to the pain experience for patients hasn't been substantiated. And then on to this newer concept of nociplastic pain in rheumatoid arthritis. And this begins in the joint. And we've talked through the various mediators which we're all familiar with, which lead to activation of the nerves. But these same mediators can lead to sensitization of the nerves as well, i.e. the reduction of the nerve depolarization thresholds of the nerves. And after frequent hits of inflammation, after frequent experiences of peripheral sensitization, all this comes together to cause remodeling of the nervous system, so-called central sensitization. And this central sensitization leads to decreased thresholds to peripheral stimuli, to increased expansion of receptive fields, increased spontaneous activity of the nerves. And for the patient, this is experienced as hyperalgesia, spontaneous pain events, and allodynia. So, do these theoretical concepts that I walked you through translate into reality for our patients? Well, let's look at some clinical data, and this aligns very nicely to some data that we've already heard from Nick. This is actually data from the UK's biological registry and hones in on those patients who have received anti-TNF therapy and done remarkably well. They're patients who have no swollen joints and a normal ESR after 1 year of therapy. And what this chart shows is that even these patients who have done really well in terms of having their inflammation put into remission, they still report significant pain. In fact, 50% of these patients report a 1 standard deviation greater level of pain compared to the general population. So what does that tell us? Well, it tells us that the traditional nociceptive drivers of pain, the inflammation, even once that's been washed away, patients still have significant pain, and therefore are there other mechanisms at play here? Could centralized mechanisms, the nociplastic mechanisms that I've alluded to, could they be contributing to rheumatoid arthritis pain? Well, the prototypical nociplastic disorder is fibromyalgia. And it's interesting to note through epidemiological studies that up to a quarter of rheumatoid arthritis patients fulfill the criteria for fibromyalgia, and that's compared to 1 to 5% of the general population. So that suggests that nociplastic pain, as measured by the surrogate of fibromyalgia, does have a significant role in this patient population. What about biomarkers that can support the supposition that rheumatoid arthritis isn't just about nociceptive pain? Well, in fibromyalgia, again, we can do quantitative sensory testing, which looks at many things, but including pain thresholds. And in fibromyalgia, patients' pain thresholds are reduced across the body. In rheumatoid, traditionally, pain thresholds are reduced around the affected joints. However, what this data shows is that amongst those patients with higher end fibromyalgia scores, these patients also have reduced pain thresholds in regions which are nothing to do with the affected joints, in this case the tibia. So a bit like what we observe in fibromyalgia, certain patients of rheumatoid also have reduced pain thresholds. Myself and many others have been interested in looking at the neurobiology of nociplastic pain in patients with rheumatoid and beyond. Many years of work have helped us categorize the major pain networks which are involved in processing pain in the human being, and involves multiple different regions, including the insula, the thalamus, the prefrontal cortex. So we know a wee bit about what's going on in the brain in normal humans, but what we don't know is what's going on in patients who have been affected with diseases such as rheumatoid. And ways that we can explore this is using techniques such as functional MRI, which exploits the fact that oxygenated and deoxygenated hemoglobin produces differential paramagnetic strengths, which can be measured by the MRI machine. And this difference is called the bold signal. And the bold signal is a surrogate marker of brain activity. And given that pain is complex, we know there's not just one region of the brain which is culprit here. We look at how different regions of the brain communicate with each other. And here you can see that we're interested, as this example shows, of how the cingulate communicates with the insula. And we look at the time series of their bold signals. And from this, you can hopefully see that the time series shows that there's similarity in the bold signals. And the assumption that we make from that is that maybe these two regions of the brain are communicating together in the context of an outcome of interest, which in this circumstance is pain. And in the context of nociplastic pain, many studies in many populations have shown that communication between the default mode network and the insula, and in particular hyperconnectivity between these two regions, is very much a hallmark of nociplastic pain. And this has been shown by colleagues in Michigan to be really the best biomarker of fibromyalgia. And amongst fibromyalgia patients, DMN to insula connectivity positively correlates with pain intensity. And we've also shown this in rheumatoid. And we've shown that this very connection increases hyperconnectivity as patients report higher levels of nociplastic pain as measured by the fibromyalgia score. So what does this all mean for our patients though? So what? Well, coexisting fibromyalgia or coexisting nociplastic pain, if I may, clearly impacts on patients' outcomes. This is some nice data from Fred Wolf showing that rheumatoid arthritis patients with fibromyalgia have far poorer quality of life compared to rheumatoid arthritis patients without fibromyalgia. Furthermore, they're twice as likely to be work disabled, they're more likely to fall into the poverty trap, they're more likely to be divorced. So having this form of pain is clearly rather impactful for our patients. And it makes our job pretty hard as well in assessing patients, because actually coexisting fibromyalgia inflates DASH scores by approximately 1 point, which can be the difference between somebody going on a biological therapy or not. And it's perhaps no surprise that RA patients with coexisting fibromyalgia are twice as likely to be prescribed a biologic. Whether they benefit from that, though, is a very different question. And of course, these aren't pristinely safe drugs. They have their issues. And there are concerns that in some circumstances we may be over-treating patients' pain with rheumatoid arthritis with biological therapies when actually they'd benefit from a different approach. And what could this different approach be? Well, Peter's going to talk a lot about how we can reduce nociceptive pain. How can we reduce nociplastic pain? Well, I think we should be learning from the fibromyalgia populations and studies, and EULAR have produced some nice guidelines in this respect. For fibromyalgia patients, we're focusing on physical activity. And if those two interventions don't help, then a stratified approach where if patients are experiencing pain, depression, anxiety, we should be delivering psychological therapies such as mindfulness, as Peter mentioned, or CBT. If they have severe pain and sleep disturbance, then thinking around drugs such as duloxetine may be an option. And then, of course, there's the far end of the spectrum who often require multimodal interventions. So we do need to be borrowing and learning from other clinical populations to help our rheumatoid arthritis patients. And this is my final slide, something that Nick touched on as well in terms of duloxetine as an agent which helps pain, and certainly there's good evidence for that in fibromyalgia. But this is a very interesting study from Japan, which looked at patients who have rheumatoid but are in remission, but still had pain, and they received duloxetine. And you can see that the group that did had improved pain scores as a result. So it's really all about trying to look at the patient, trying to understand what are the mechanisms driving their pain, but also recognizing that there could be coexisting mechanisms as well. Very rarely is a one or the other. So looking forward to having some questions.
So Neil, perhaps I can thank you for a really exciting and interesting talk. And I think the advances in contemporary neuroimaging are completely changing the way we think about all of these issues. But it's still a real conundrum to sort it out in the clinic. And in fact, we've had a very interesting question that's very relevant to this that's come in. Thanking you for the excellent presentation and saying that providing the persisting pain in patients with controlled disease activity or even remission is not fibromyalgia, how can it be explained? Is it neuroinflammation which cannot be tackled by anti-inflammatory treatment, or what would your feeling be about that?
So thank you. It's a great question. I think my first point I'd like to make in that regard is to encourage the community not to think of fibromyalgia as an all or nothing construct, but rather a continuous construct. Whatever we want to call it, whether it's central sensitization or nociplastic pain, and I do apologize that there are so many terms out there which can be very confusing, but you essentially get to the same thing. And for me, even if somebody doesn't fulfill fibromyalgia criteria, I still quite often use the fibromyalgia survey in clinic, and patients who have scores which might not fit the 12 cutoff but are just below that, they still have those mechanisms at play which should be treated and targeted in the same way that I've just alluded to with a non-pharmacological approach. But it's not to say that everything that's residual after we've treated the inflammation with our fancy biologics is necessarily nociplastic pain. There's still so much for us to learn. I'm sure there's going to be an overlap. I'm sure there's going to be an interaction between inflammation and brain, as the question alludes to. And we're doing lots of work to try and understand that communication between the periphery and the central area. There's so many different ways that the peripheral inflammation could get to the brain, whether it's directly via the blood-brain barrier, via the vagal nerve. But sorry, I don't have a precise answer to that, but I assure you many of us are working hard towards that.
Thanks, Neil. And I can see on the chat that, and this is very relevant. In fact, only today, one of my patients who has rheumatoid arthritis was waxing lyrical about the anti-inflammatory diet that she's just tried. Have you got any comments on diet and pain and rheumatoid arthritis?
I mean, I think like you, Nick, have many patients who have provided really compelling anecdotes about the changes that they've made to their lifestyle, including their diet, and the impact that's had on their symptoms. There clearly is something there. From a scientific perspective, I know it's a very challenging area to study. So many different complexities, but I do know that particularly looking at sort of metabolic pathways has been one area of interest. Technologies are starting to catch up now to enable us to appropriately characterize these pathways, and then hopefully downstream we will be able to get a better sense of the sorts of diets that we should be recommending our patients. Again, I think that's something in the future, and there's certainly, to my knowledge, no specific clinical trial evidence or even decent mechanistic evidence to push us in the right direction at this stage. But I would fully agree that it is an area of unmet need which requires greater inspection.
course, we mustn't forget that some diets will help with the inflammatory component of disease, and there may be residual inflammation causing some of the ongoing pain. So again, it's a very complex area to disentangle, isn't it?
No, I fully agree, Peter. A lot of work still to be done, and one of the reasons why I quite enjoy this particular forum is that I know there's a mixture of clinicians and scientists, and for the scientists who are on the call, if you need inspiration to focus in on a major unmet need, I would please encourage you to explore pain in the context of not just inflammatory diseases, but chronic pain generally. There's a great need. Thanks for that. With that, I think we should quickly move on to hear Professor Taylor's next presentation. I've known Peter for a long time. He trained in Cambridge and Oxford. He gained a PhD at the University of London. He currently holds the Norman Collison Chair of Musculoskeletal Sciences at Oxford University, where he's also Director of Clinical Sciences. He has specialist clinical interests in novel therapies, in rheumatoid and early arthritis, and his research involves use of targeted therapies to understand pathogenesis of disease, as well as use of novel outcome measures. Really looking forward to hearing you talk, Peter. Thanks for your time.
Thanks so much, Neil. And thank you to the organisers, and also a pleasure to join this audience. Well, having heard the discussion that we've all been having just now, I'm going to start off by giving one of my favourite quotes, which is from Sir William Osler. And for any of the scientists on this call, perhaps I should explain that he was a very famous physician and indeed the Regius Professor of Medicine in Oxford over a century ago. And he said that the good physician treats the disease, but the great physician treats the patient who has the disease. And I think that's what we all aspire to do. But of course, in order to do that optimally, we have to understand the underlying pathology. And I think that's really what we're trying to get at here. And one of the ways we can try and understand things further is to use targeted therapies as probes of pathogenesis. So I'm going to talk a little bit about JAK inhibitors in the context of management of pain. And we're going to consider, first of all, that the management of pain, as Nick and others have alluded to throughout this discussion, is absolutely multimodal. So it includes pharmacological interventions, psychological interventions, and exercise-based interventions. And some of the traditional pharmacological interventions are very familiar and in some ways, sadly, have not advanced a great deal over time. So NSAIDs, opioids, paracetamol, and of course then the drugs that suppress inflammation, where we have had significant advance. Then there are psychological interventions which have been referred to: mindfulness-based stress reduction, sleep interventions, cognitive behavioral therapy, to name but a few, and exercise-based interventions which Neil referred to with respect to fibromyalgia. So we've known about these interventions for a long time, but integrating them appropriately is really not always an easy matter. And as I've been asked to talk about the pharmacological intervention primarily, this particular slide is really just a reminder that what we need to think about is what is the type of pain and the cause of pain, and Nick's delineated this very nicely. Is there residual inflammation or not? Are there comorbidities that might be influencing the disease expression, particularly depressive disorders, as we've heard? And then we need to think about the therapeutic algorithm. And essentially, in patients where the inflammation has been optimally treated, and I can't stress enough that we should do our best to treat to target and optimally suppress inflammation and allow immune homeostasis to be restored. But then we have the option of paracetamol, non-steroidal anti-inflammatory drugs, of which, of course, there are many, weak opioids, plus or minus paracetamol, and only in exceptional cases would one think about stronger opioids. And then there are what we might call adjuvant therapeutic options. And again, Nick has discussed this beautifully: tricyclic antidepressants and neuromodulators. But when to use these and how to use them optimally is still a very difficult issue. Now, If we are to go on and think about some of the pain outcomes in clinical trials and JAK inhibitor trials in particular, I think it's worth just taking a moment or two to acknowledge some of the extreme limitations of the tools we have at our disposal. Now, the first point to make is that the way in which we measure pain in clinical trials has all the sophistication of an orthopedic surgeon. That is to say that there is a 10-centimeter line on which you scrape a mark, and actually it doesn't even refer to the bit of the anatomy that's potentially causing pain or in which pain is experienced. So it is a very, very blunt instrument. But then we tend to look at the degree of improvements in terms of absolute change, and we might talk about a minimally clinically important difference or a 30% or more improvement, which might be regarded as a moderate degree of improvement, or 50% or more, which might be substantial. And then there's the pain state that's achieved. So for example, if a patient achieves a pain threshold that's below 10 millimeters out of a 100 millimeter scale, could we say that that's actually normal? And of course, these are very difficult issues because they're very subjective measures. Then there's the issue of combinations of improvement and state. And when should you evaluate an improvement? Should we look at early points, or do you have to wait until there's a plateau of response? Generally speaking, if a patient responds early, they tend to have a better long-term response. And we have to recognize the limitations of placebo-controlled trials, where these days the placebo arm will usually only be 12 weeks at maximum for ethical reasons. And yet we know that there may be a very robust placebo response when it comes to pain. But nonetheless, and again, Nick's alluded to this, that there's a very strong concordance between good pain relief and improvements in numerous measures of quality of life, including fatigue, sleep, and depression that we've been discussing so much. So you can see on the right-hand side a graph for mean reduction in pain for methotrexate as compared with two different doses of tofacitinib. And you can see that both the tofacitinib doses give a better pain relief numerically on average than is the case with methotrexate. And this is in an early arthritis population. And in fact, in that population, you would expect methotrexate to have a very good response. Now, many of us have become very familiar with TNF blockade over the last 2 decades, and we know that it's a very potent and effective treatment, not for all patients, but it is for many. And if we look at patient-reported pain with TNF blockade, you can see that in this particular graph, that placebo gives a really minimal response. There are other studies where there's a much bigger placebo response than this. But TNF blockade in this particular case with sertolizumab pegol gives a nice improvement which differentiates from placebo from a very early time point. So that begs the question as to whether single cytokine inhibition and improvement in pain might differ from multi-cytokine inhibition. And we have to remember here, of course, that pain is a generic feature of inflammation. But as we've heard so beautifully from Neil, there are also drivers of pain that are not necessarily inflammatory in origin. So let's now look at the impact of JAK inhibition on patient-reported pain in rheumatoid. And we'll come back to tofacitinib again, because this was the first JAK inhibitor to be improved on a global basis. It's said to be predominantly a JAK1/3 inhibitor. You can see that 2 doses of tofacitinib were tested in this particular trial. It's a monotherapy trial, which is why I'm showing you, because it gives you a very pure idea, really, of the impact of tofacitinib. Only the 5 milligram BD dose is currently approved, and you can see once again that there's a rapid response and that it differentiates very nicely from placebo. When the placebo patients are crossed over to active treatment at 3 months, they rapidly catch up. Now here, looking across a number of trials in different rheumatoid populations, we can see monotherapy on the left, then we can see tofacitinib in combination with conventional synthetic DMARDs, in methotrexate inadequate responders in combination with methotrexate, and then we can see after biologic inadequate response on the right-hand side. And what this is telling us really is that we're seeing a magnitude of pain relief with JAK1/3 inhibition that is at least that expected with a biologic anti-TNF. And in fact, in the oral standard study, there was a TNF inhibitor as a comparator. The study, however, wasn't sufficiently powered to look directly at the difference. So how do TNF inhibition and JAK inhibition compare in terms of pain resolution? And to do that, we really need to look at studies that are powered head-to-head, where you have both an anti-TNF and a JAK inhibitor. And what I'm showing you here is data from the RA-BEAM study. And on the left-hand side, you can see a result for elicited pain. So this is the tender joint count. And on the right-hand side, you can see the result for experiential pain. And what's very striking about this is that both active treatments, TNF blockade and JAK1/2 inhibition, differentiate from placebo very rapidly, and that difference is maintained throughout the dosing exposure. But what is really fascinating about this, and the first time that it was shown, is that when you look at experiential pain, JAK1/2 inhibition differentiates from anti-TNF, and that difference is statistically significant and maintained throughout 52 weeks of exposure. So it was a really striking and not necessarily a result that we had expected. And you can see circled here the rapidity of onset with JAK inhibition in particular. Now, there are similar data for select compare. This is with upadacitinib, which is somewhat more selective for JAK1. And here, again, if we look at the mean pain reduction, you can see that upadacitinib differentiates not only from placebo, but also from adalimumab, which was a comparator. And at some points through the 48 weeks of dosing, there was a statistically significant difference between upadacitinib and adalimumab. So this begs questions about whether there are differences between JAK inhibitors, whether the improved pain relief we see with JAK inhibitors is simply because they reflect multi-cytokine inhibition, and it really deserves more research. Now, another preferential JAK1 inhibitor is filgotinib, which has been tested in a very comprehensive set of phase 3 trials, which are illustrated here. And I know this looks horribly busy, for which I apologize, but to make life easy, we'll just highlight some results. So if we look at 52 weeks of drug exposure in the Finch 1 study, you can see that in the red column, filgotinib 200 milligrams once daily plus methotrexate gives a better magnitude of pain relief numerically than with adalimumab plus methotrexate. And if we look at the patients achieving a 90% reduction in baseline, so this is a huge reduction from baseline, 25% of the filgotinib 200 milligram patients achieve that. Now, if we look over on the right, this is another population again, and here you can see 2 doses of filgotinib compared with placebo plus conventional synthetic DMARD, and again, the differentiation between filgotinib and placebo is very obvious. And over on the right-hand side in Finch 3, where we're looking at a population who have early arthritis, you can see methotrexate as a comparator, and you'd expect methotrexate to work quite well in early phase rheumatoid. But again, you can see the differential in terms of pain relief on average between filgotinib, particularly at the higher dose, and methotrexate. So when we think about the magnitude of pain response, neurologists have looked at this and they have validated the following thresholds. They've talked about minimally important improvements being about a 10 to 20% decrease from baseline, moderately important improvements being 30% or greater decrease from baseline in pain, and substantial improvements being at least 50% improvement in pain. And because what I have shown you so far has represented the average improvement, with respect to the data from the RA-BEAM study, we wanted to look at this in more detail and ascertain what the variability was within that average improvement. And here I'm showing you data for patients who achieved a 50% or greater improvement after 6 months of drug exposure, and this would be considered a substantial pain improvement. And what's very striking is that both active treatment arms, the baricitinib, a JAK1/2 inhibitor, and the anti-TNF, differentiate from placebo, but numerically, more patients are achieving this substantial improvement with baricitinib than is the case with adalimumab, and that difference is statistically significant. Furthermore, the median time to achieve this improvement is half with baricitinib than it was with anti-TNF. So in order to try and understand this a little bit further, my colleagues and I undertook further post hoc analysis. And what we did here was to ask the question, is the difference, the apparent difference between baricitinib and adalimumab, just simply because baricitinib is a multi-cytokine inhibitor and therefore may have a deeper effect on inflammation suppression? So we took the available surrogates of inflammation, which were CRP, ESR, and swollen joint counts, and we undertook mathematical modeling called a multiple mediation analysis so that we could understand the contribution attributable to these three surrogates of inflammation in terms of the total change in pain. And the results, again, came as really quite a surprise, and they're illustrated in the histograms on the right. And what we saw was that when you look at the surrogates of inflammation, in fact, there's a very similar contribution in terms of pain relief when you look at multi-cytokine inhibition or single cytokine inhibition. And we called this the indirect effect on pain. So in other words, the proportion of pain relief that's attributable to inflammation suppression, and pain is a generic feature of inflammation. But when we looked at the direct antinociceptive effect, then in fact, you could see that it's much greater with baricitinib. But I may be wrong in calling it an antinociceptive effect, because of course it could be an antinociplastic effect, and this is something that needs more investigation. So just to finish up and simply to speculate, the sorts of data that I've shown you, I think, are absolutely fascinating. They're certainly of great clinical relevance to all of us who see patients who have pain, whether with active inflammation or residual pain after inflammation has apparently been suppressed. But what might the mechanisms be, and what hypotheses do these data generate? Well, if we think about the cytokines that we know that signal through the Janus kinase pathway, there are many, and some of them are illustrated here. And indeed, we also know that there will then be downstream modulation of other cytokines, including TNF and NGF that Neil mentioned. One of the cytokines Neil didn't mention in his slide that showed peripheral nociception, interestingly, was GM-CSF. And we do know, and there's abundant evidence in animal models, that GM-CSF is a particularly important mediator of peripheral nociception. And GM-CSF signals through JAK2 homodimers. So again, there's a potential hypothesis that might explain any difference, if there is a difference, between different members of the JAK inhibitor class. But I must stress that at the present time, in the absence of head-to-head studies, it remains speculative. So I think there's a lot of evidence that cytokine modulation not only improves experiential pain, but there's accruing evidence that some of these mechanisms may be independent of the directly inflammatory process. And this certainly merits further investigation. And of course, neuroimaging will shed a great deal of light on this. So in summary, what we've heard, in fact, beautifully from Nick at the beginning, is that pain remains a foremost burden to patients. It affects how they perceive their disease and obviously their quality of life. And it's quite a burden for us rheumatologists from a practical point of view as well. It's not an easy, at least I don't find it an easy thing to treat. We've seen robust and rapid pain relief in rheumatoid arthritis with JAK inhibitors across the class. And we really must recognize that we shouldn't underrepresent the substantial impact of chronic pain on our patients' lives. And this may occur if we follow treatment algorithms that are simply based on diminishing composite scores of disease activity. It comes back to my introductory quote from Osler. If we simply treat the disease activity score, we may be being good physicians, but perhaps not great physicians. And in order to better understand and approach this, we really need to know what the mechanisms are underlying the effects of baricitinib and other JAK inhibitors on apparently non-inflammatory pain, and to tease out these mechanisms further. And the good news is all of this this sits in the context of a real revolution in understanding some of the therapeutic targets in the analgesic pathway. And so I think there's great hope for real improvements in our ability to treat patients as we go forward. So thank you all very much for your attention. And I'll now pass back to the panel, I hope. There we go.
Fantastic as always, Peter. Thank you so much, and really intriguing data, as you say. So let's see if we have any questions coming through. So here's one. Thanks for the great presentation. Can we initiate JAK inhibitors rather than TNF therapy in treatment of rheumatoid to help with pain management?
Yes, thank you very much. I think it's a really important practical question, and the answer is yes. I don't know whether this CSF forum is being broadcast beyond the UK, but of course the rules and regulations in terms of access to JAK inhibitors have changed recently. We've had upadacitinib and filgotinib both approved by NICE recently for patients with severe disease, but I'm pleased to say that filgotinib is also available for patients with moderate disease activity. And NICE, EULAR, and well, certainly NICE and EULAR until recently, ACR recognized that JAK inhibitors could be used after failure of a first conventional synthetic DMARD. So I personally think that when we think about advanced therapies, meaning biologics or small molecule therapies, that we should take into account the patient preference around oral versus parenteral, but we also very much need to take into account the comorbidities a patient has or indeed might be susceptible to. And one of those domains is absolutely pain. So for patients where pain is a dominant feature, I think JAK inhibitors are worth thinking about as a first-line advanced therapy. But the other situation, which the questioner didn't ask about, is what about the patient who, for example, has had a good response to a composite score to an anti-TNF, but still has residual pain? And would you consider, if you could access and reimburse the medication, to swap to a JAK inhibitor? Well, I certainly would consider that as an option. But again, we need to have shared decision-making with the patient, looking at the totality of likelihood of benefit and risk.
Peter, I was very excited about that data that you were showing. And I've got a couple of questions, actually. I don't know whether you can actually give a bit more insight if you've had access to more outcome data from those studies. Did they collect data on mood, like depression and anxiety, or even out with those studies? Are you aware of any other studies that have looked at,
yes,
at the JAK inhibitors on mood?
So it's a great question. We do have some data. So actually one of the other real advances in clinical trials, and I think in the slow march towards a more holistic approach to care, has been that the regulators themselves, and with a demand from the patients, are now adopting many more patient-reported outcomes in clinical trials. So across the JAK inhibitor clinical trial programs, there were around about 7 different PROs collected, which is many, many more than in the early days of biologics. And of course, one of the PROs collected is the SF36, which includes a mental health component and a physical component. And so there are improvements in the mental health component. These have been published and written up for the different JAK inhibitors. But to the best of my knowledge, there hasn't yet been very granular data looking very specifically on more detailed measures of depression and more sophisticated outcome measures, of which there are many. There is a study going on in major refractory depression with a JAK inhibitor at the moment, an MRC-funded study, which I'm privileged to be part of. I can't yet disclose any data because the study is ongoing. It's a very short exposure to JAK inhibitors. There have been studies looking at IL-6 ligand blockade in mood disturbance, as I'm sure you're aware, and they showed some degree of efficacy, but it was relatively restricted. It was slightly unfortunate because the investigators, I'll name no companies, although I might have given it away with my comment about IL-6 ligand, but it may be slightly unfortunate that the companies chose an IL-6 ligand blocker because there are some theoretical reasons to think an IL-6 receptor blocker might be better because of blocking both trans and cis signaling. But in terms of JAK inhibition, this is an area of very active research.
Thank you.
Really interesting. I think we could talk for a while yet, but in the interest of time, because we've run over a wee bit, I just really wanted to thank my co-hosts this evening, Professor Peter Taylor and Dr. Nick Schenker. I hope everyone listening in enjoyed the talks. Thank you for listening to us and providing some really great questions. I hope you've all taken away a little nugget of information that might help your clinical practice or inspire you from a research perspective. So thank you.
Thank you very much, Neil. And Peter, it's good to see you.
Yeah, great. Thank you very much, both of you.